Good evening to each and everyone here. I am thrilled to welcome you all for today's informative webinar on female pelvic anatomy. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Raisa Samuel. Dr. Raisa, an accomplished medical professional, holds an MBBS, DGO, and an MS in Obstetrics and Gynecology from prestigious college CMC Vellore. She has further specialized with a postgraduate diploma in family medicine from the same institution, reinforcing her commitment to providing holistic and comprehensive women's health care. Dr. Raisa's expertise in obstetrics and gynecology is well supported by her significant contributions to medical research. Dr. Raisa's dedication to both clinical practice and academic research underscores her role as a key figure in advancing obstetrics and gynecological care in India. Over to you, Doctor.
Good evening, everyone. I hope I am audible.
Yes, Doctor, you are audible.
Okay. So today's webinar is on female pelvic anatomy. It's a very comprehensive topic and it's mainly theory. So we have the female reproductive system, which main functions are to produce the egg, that is the oocyte production, fertilization, pregnancy and childbirth, hormone production, and mainly they are divided into the external genitalia and the internal reproductive organs. So the outline of today's class, we will be dealing with the anterior abdominal wall anatomy, the external genital organs, the internal genital organs, their nerve supply and blood supply. So overview of the structures, the external structures, the vulva, which is consists of mons pubis, labia majora, labia minora, clitoris and vestibule. The internal structures are vagina, cervix, uterus, fallopian tubes and ovary. So going on to the anterior abdominal wall. So when we see the anterior abdominal wall, we go from the superficial to the deep. So this is for both the surgical or the anatomical context. So from the outer to the inner, the layers are very crucial. So first we encounter the skin, then the superficial fascia, that is the divided into campus fascia and scarpa's fascia. Campus fascia is the fatty superficial layer and scarpa's fascia is the deep membranous layer. So while doing cesarean section, we will be, or any hysterectomy or any abdominal surgery, we'll be encountering all these layers. Then we go on to the next layer, that is the muscle and the aponeurosis. These are the core muscles. Then next layer will be the transversalis fascia, a thin layer between the muscle and the fat. Then there is extraperitoneal fat, and then we enter into the parietal peritoneum. Peritoneum is the glistening inner lining of the abdominal cavity. Inside this are the visceral organs. So this is the diagram which shows the skin. Then next is the fatty layer, that is this is the campus fascia. So and here is the membranous layer, that is the scarpa's fascia. These both constitute the superficial fascia. Then you have the muscle, which is external oblique muscle, internal oblique muscle, transversus abdominis muscle. This is the fascia which we were talking, fascia transversalis, extraperitoneal tissue which has minimal fat, and then we enter the parietal peritoneum. Skin, there are different changes that occurs in the skin of a female. So during pregnancy, there is pigmentation which appears along the midline, forming the linea nigra. And when the skin starts to stretch during pregnancy, it's called the stria gravidarum. So the stretch marks that you see on a pregnant patient on the skin is called the stria gravidarum. So what are the anatomical landmarks of the abdominal skin? So these are specific features which are very critical. So umbilicus, as you all know, that is the scar remnant of the umbilical cord. It is the consistent landmark for T10 dermatome. So when we give spinal anesthesia, when usually we check at the umbilicus, that means we have anesthetized at the level of T10 dermatome. So next is the linea alba, which is the often visible as a slight vertical groove. So you can see a straight line, linea alba. usually in fit individuals. This is marking the midline fusion of the rectus sheath. Then you see the inguinal crease, that is the fold between the lower abdomen and the thigh overlying the inguinal ligament, so that both sides you can see the inguinal crease. What are Langer's line? These are topological lines representing the orientation of the collagen fibers in the dermis. This is on the abdomen. They generally run horizontal. These are the horizontal lines that you see on the abdomen. So what is the significance of this Langer's line? Incisions made parallel to the Langer's line will heal with minimal scarring, while if you make incision across them, it is under more tension and may result in keloids or wide scars. That is why we usually give incision which is parallel to the Langer's line. So what are the innervation or the dermatomes of the skin? The skin of the anterior abdominal wall is innervated by the anterior rami of the spinal nerves, that is T7 through the L1. T7 to T9 will give the skin superior to the umbilicus. T10 is at the umbilicus, and T11 to L1 is skin inferior to the umbilicus. We have to know this because when we are doing surgeries, when we touch, we usually check by touching the skin. So we know at what level the anesthesia is given. Now going on to the next layer, that is the subcutaneous fascia. As we already said, it is divided into two. There is this two split layer, and the first part is the campus fascia, which is the superficial fatty layer. It consists of thick yellow adipose tissue. What is the function of it? Is usually as a thermal insulator and energy reservoir. It is continuous with the superficial fascia of the thigh and the rest of the body. So it continues with the rest of the body. Next layer is the scarpa's fascia, which is the deep membranous layer. It is composed of thin, tough, collagenous membrane with very little fat. So what is the clinical significance? It is deep to the campus and superficial to the muscle aponeurosis. So where is it attached? It blends with the fascia lata, which is deep fascia of the thigh, just below the inguinal ligament. There is fluid tracking because it fuses with the deep fascia of the thigh. It prevents the abdominal fluid, that if there is a rupture of urethra or if there is urine collected, that will prevent from going into the legs, directing it towards the labia. What is the importance of knowing these layers? So the surgeons often specifically close the scarpa's fascia with sutures because it is distinct, strong membrane. It provides a holding power for the wound, preventing tension on the skin and reducing scarring. And also in cases of liposuction, most abdominal wall liposuction occurs within the fatty space of the campus fascia. So this is the surgical importance of knowing the superficial fascias. Now the next most important layer of the abdomen wall is the rectus sheath. So the rectus sheath is usually formed by the external oblique, internal oblique, and transverse abdominis muscle. So however, its structures changes significantly depending on where you are in the abdomen. So usually the arcuate line, I'll be showing the diagram. So above the arcuate line, that is the superior 3/4, in the upper abdomen, the rectus abdominis is fully encased. That is, it has, here you can see that above the arcuate line, this is the rectus abdominis, this is the rectus sheath. So it is fully encased. By what? Anterior wall is formed by the aponeurosis of the external oblique and the anterior half of the internal oblique. This is the external oblique and this is the internal oblique. So this is the anterior wall is formed by this. This is the anterior wall. And the posterior wall is formed by the posterior half of the internal oblique and the aponeurosis of the transversus abdominis. This is the transversus abdominis. So this is the skin, the campus fascia. This is the scarpa's fascia. You can see the thin membranous layer. Then we are talking about the rectus sheath. This is the rectus sheath. So it is formed, anterior wall is formed by the external oblique and the internal oblique part, and the posterior wall is formed by the part of the internal oblique and the transversus abdominis. So it is fully encased above the arcuate line. Now what happens below the arcuate line? So below the arcuate line, about midway between the umbilicus and the pubic symphysis, the rules change. Anterior wall, all three aponeuroses, that is of external, internal, and transversus abdominis, pass in front of the rectus muscle, and posterior wall, there is no bony or fibrous sheath behind the muscle here. Only the thin transversalis fascia and the peritoneum is present. So this is the below the arcuate line. What happens? Anteriorly, you have the internal oblique, external oblique, and the transversus abdominis covers it. Posteriorly, the wall is deficient of anything. It's only the transversus, only the transversalis fascia and the parietal peritoneum. So you can see that posteriorly it is deficient. So why is rectus sheath so important? What are the contents of the rectus sheath? It is not just a muscle holder, it is a protected conduit for vital structures. So we are very meticulous in closing the rectus sheath. It should be closed very tightly, because if it gives way, then you have a burst abdomen. So it is very significant in closing the abdomen after any abdominal surgery. Rectus sheath has to be closed properly. So the muscles what are the muscles of the rectus sheath? It is the rectus abdominis and pyramidalis. Pyramidalis, sometimes only you will see if there is repeated surgeries, then pyramidalis muscles may not be visible. Then what are the arteries or veins? The superior and the inferior epigastric vessels, they anastomose connect within the sheath to provide collateral circulation. So often when we do surgeries, we come across the superior and inferior epigastric vessels. Nerves, the terminal ends of the lower 5 intercostal nerves, that is T7 to T11, and the subcostal nerve T12 also are encountered, are the contents of the rectus sheath. What is the clinical significance of the arcuate line? So this is the weak point of the abdominal wall. Arcuate line, it is like a crescent-shaped horizontal line where the posterior wall of the sheath ends. So why is this significant? There is something called as Spigelian hernia. It's a hernia that forms. These occur at the lateral border of the rectus sheath. So lateral part of the rectus sheath, if the arcuate line is weak, then the contents will often near the level of the arcuate line where the structural support shifts. So there it can form hernia. Hematomas, again, after any surgery, if we don't do proper hemostasis, rupture of the inferior epigastric artery can cause a rectus sheath hematoma. This is usually below the arcuate line. These can spread more easily because there is no posterior wall to contain the blood against the muscle. So arcuate line is very important, because at this point below there is nothing, it's just the transversalis fascia. So the hematoma can spread. So this is above the arcuate line. To summarize, that anterior wall is formed by the external oblique and half of internal oblique, and below the arcuate line, it's all the three aponeuroses: anterior, external, internal, and transversus abdominis. In posterior wall is by half of the internal oblique and transversus, and below the arcuate line, it is only transversalis fascia. So strength, it is very strong and balanced above the arcuate line, because you know that it is well encased, and below the arcuate line, it is anteriorly strong but posteriorly weak. Now going on to the anterior abdominal wall muscles. So the muscles of the anterior abdominal wall are external oblique, internal oblique, transverse abdominis, rectus abdominis, and pyramidalis. There are 5 muscles in the anterior abdominal wall. Here you can see the external oblique, internal oblique are here. This is the internal oblique. You can see in this diagram. And rectus abdominis muscle is here. This is the linea alba that we were saying, the midline line. Transversus abdominis muscle is here. Internal abdominal oblique muscle is here. Inguinal ligament you can see here. Pyramidalis muscle is here. This triangular shaped muscle is called the pyramidalis muscle. And this is the cremaster muscle, which is not present in females. The three flat muscles, that is lateral, these muscles are layered on top of each other. Their fibers run in different directions to create a cross-hatch plywood effect for maximum strength. So these are the flat muscles. What are the flat muscles? External oblique, internal oblique, and transverse abdominis muscle. So external oblique, it usually runs inframedially. Where does it origin from? From the ribs 5 to 12, and they are inserted into the linea alba, pubic tubercle, and anterior half of the iliac crest. So here in this diagram, you can see the cut edge of the internal oblique. This is the posterior lamina, that is the rectus abdominis. This is the arcuate line. Here is the arcuate line. And behind that is the transversalis fascia. This rectus abdominis muscle, which runs transverse vertically, is cut here, and this is the cut edge of the external oblique muscle here, aponeurosis. Next is the internal oblique muscle, that is it runs supromedially, that is perpendicular to the external oblique. Where does it origin from? Thoracolumbar fascia and anterior 2/3 of the iliac crest. It's inserted into the inferior borders of the ribs 10 to 12 and linea alba. Transversus abdominis muscle, that is the deepest layer. Here the fibers run horizontally or transversely. Function is it acts like a natural corset. So it is very strong, and it provides a corset, acts as a natural corset. And it provides core stability but does not move the trunk much. So the key feature is its primary job is increasing the intra-abdominal pressure for forced expiration, coughing, or defecation. So it is the most strong muscle that is present in the abdominal wall, which gives you, actually protects you when you are forced expiration or coughing and defecation. That is the muscle which becomes taut. So this is the rectus abdominis muscle. Here you can see this. And it is attached to the linea alba. The muscle, the aponeurosis, and that gets attached to the linea alba. Now going on to the two vertical muscles, that is rectus abdominis and transverse abdominis was the horizontal one. Now going to the vertical one is the rectus abdominis, which is this long, broad, strap-like muscle, tendinous intersections, 3 or more fibrous bands that cross the muscle, creating the segmented look of the abdominal muscles. What is the function? The primary flexor of the lumbar spine. The small triangular muscle is called the pyramidalis muscle, which is found at the very bottom of the rectus sheath. It is absent in about 20% of population, and function is it tenses the linea alba. And in recurrent surgeries also, sometimes that muscle gets toned apart, so it might not be visible. Now, what is the clinical significance of these abdominal muscles? Inguinal hernia, which occurs when the abdominal contents protrude through a weak point in the lower abdominal wall, is often related to the inguinal canal. Inguinal hernias are not very commonly seen in female. Female incisional hernias or umbilical hernias are seen more commonly than inguinal hernia. Incisional hernia occurs when the abdominal muscles fail to heal properly after surgery. So after cesarean, or if there is a midline scar, laparotomy has done. So from that, incisional hernia could occur. So this abdominal muscle, usually we stretch the muscle during the surgeries. So because of that, the muscle becomes very weak and hernias can occur. Now going on to the fibrous layer that is lying deep to the transverse abdominis muscle and is separated from the peritoneum by the preperitoneal layer of fat is called the transversalis fascia. What is peritoneum? After going through the transversalis fascia, you reach the peritoneum. This is the part of the parietal peritoneum that covers the abdominal cavity. It is a thin glistening layer. It's like a flimsy glistening layer that is seen, which covers all the visceral organs. Now, what is the blood supply of this anterior abdominal wall? The superior and inferior system. This is the deep blood supply located within the rectus sheath, behind the rectus abdominis muscle. So superior epigastric artery is a terminal branch of the internal thoracic artery. How does it enter? It enters the rectus sheath superiorly and it descends. Inferior epigastric artery, it is a branch of the external iliac artery, and this is just above the inguinal ligament. It also runs superiorly along the posterior surface of the rectus abdominis. So they anastomose. These two arteries meet and join to anastomose near the umbilicus. This provides a collateral circulation between the subclavian artery and the external iliac artery at the bottom. Then the lateral system, that is, these vessels supply the flat muscles, that is the obliques and the transverses, and the lateral skin. So there is musculophrenic artery, the other terminal branch of the internal thoracic artery. This supplies the upper lateral wall. Subcostal and the lumbar arteries, that is arising directly from the abdominal aorta, they supply the lateral flank. And deep circumflex iliac artery, a branch of the external iliac artery that travels along the iliac crest. So there is a superficial superior system or the inferior system, mainly by the superior epigastric artery and the inferior epigastric artery. They will anastomose and they supply the deep blood supply of the rectus sheath and behind the rectus abdominis muscle. Lateral system is by the musculophrenic artery, subcostal and lumbar arteries, and deep circumflex iliac artery. So this is the diagram showing superior epigastric artery, inferior epigastric artery. They will anastomose at the level of the umbilicus. And this is superficial epigastric artery, which is a branch of femoral artery. This inferior is external iliac branch, and superior epigastric is the internal thoracic artery branch. And this also gives musculophrenic artery, which supplies the lateral wall, and lateral cutaneous branches of the posterior intercostal arteries. These are all the arteries which supply the lateral wall. And deep circumflex artery also supplies the lateral wall muscles. Superficial blood supply, that is the skin and the subcutaneous tissue. These are smaller vessels, live in the subcutaneous tissue and supply the skin. They all originate from the femoral artery. This is the superficial epigastric artery, which travels towards the umbilicus. Superficial circumflex iliac artery, which travels laterally along the inguinal ligament. And superficial external pudendal artery, which supplies the skin of the lower pubic region. So these supply the superficial layer, that is the subcutaneous tissue and the skin. So superficial circumflex iliac, superior epigastric, deep circumflex iliac, these are all the vessels of the anterior abdominal wall. Deep inferior epigastric artery, superficial inferior epigastric artery. These are all the vessels of the anterior abdominal wall. Now, venous drainage is generally follow the arteries of the same name. However, there is a major clinical point here, that is systemic portal anastomosis, that is around the umbilicus. Small veins called the paraumbilical veins connect the systemic drainage, that is epigastric veins, with the portal drainage, that is the portal vein. Like there is anastomosis between the arteries, here also they connect with the systemic drainage with the portal drainage, that is the portal vein. Nerve supply of the anterior abdominal wall is innervated by the anterior rami of the lower 6 thoracic spinal nerves and the first lumbar nerve. So thoraco-abdominal nerves, that is from the T7 to T11. These are the distal continuations of the lower intercostal nerves. They leave the intercostal spaces and travel between the internal oblique and transversus abdominis muscles. Subcostal nerve, that is T12, runs along the lower border of the 12th rib. Iliohypogastric and ilioinguinal nerves, these from the L1, these originate from the lumbar plexus. They supply the skin of the pubic region and the superior part of the groin. So the main nerves are thoracoabdominal nerves, internal oblique and transverse, which supply goes between the internal oblique and transverse abdominis muscle. Subcostal nerve that will run along the 12th rib, iliohypogastric and ilioinguinal nerve that goes to the pubic region and the groin. So this is the T7 to T11, then subcostal T12, iliohypogastric L1, ilioinguinal, and here reaches the inguinal ligament. Motor versus sensory supply, that it is important to note that these nerves are mixed, that is they give both motor and sensory function. They innervate the flat, motor function is they innervate the flat muscles, obliques and transverses, and the vertical muscles, rectus abdominis. The transverse incision can sometimes paralyze the segments of the rectus muscle if these nerves are served. So when you are doing a surgery and if you make transverse incision, sometimes these nerves can get damaged or cut, and this will paralyze the segments of rectus muscle. Sensory function, they provide sensation to the skin and the underlying parietal peritoneum. What is the path of the nerves? The nerves don't just sit on the surface, they travel through a specific anatomical plane. So the neurovascular plane, they run in the space between the internal oblique and the transverse abdominis. This is the same plane where the main blood vessels are also found. They eventually pierce the rectus sheath to supply the rectus abdominis muscle, and finally they exit through the skin as anterior cutaneous branches. Now going on to the perineum. Perineum is an anatomical or true perineum is a diamond-shaped region located in the inferior to the pelvic diaphragm. It is divided into two distinct triangles. So this is the two distinct triangles. So it divided by an imaginary line, that is from the both ischial tuberosity. There is an two triangles are formed. So what are the boundaries of the perineum? So we always assess the patient in a lithotomy position, which is the standard position in pelvic examination. So there are 4 points. Anteriorly, it is the pubic symphysis. Then posteriorly, it is the tip of the coccyx. Laterally, you have the ischial tuberosities, which are also called as the sitting bones. And roof is by the pelvic diaphragm, which is formed by the levator ani muscle. So here you can see both diamond shaped area that is extending from the pubic symphysis. This is the coccyx, and two ischial tuberosities. So they form two triangles. So the two triangles are called, one is called the urogenital triangle and the other one the anal triangle. So an imaginary line is drawn between the two ischial tuberosities and divides into two triangles. Urogenital triangle is the anterior triangle, and this contains the external genitalia and the openings of the urinary and the reproductive tracts. So what are the structures? Opening of the external genitalia is the vulva, which contains mons pubis, labia majora, labia minora, clitoris. Then you have the urethral opening and the vaginal orifice. So these are the structures which you see in the urogenital triangle. Perineal membrane, a fibrous sheet that provides a foundation for the external genitalia, is also seen in the urogenital triangle. So here you can see the pubic symphysis. Then this is the you can see the contents of the urogenital triangle, that is the vulva. This is the urethral opening. This is the vaginal orifice. and this is the line, imaginary line that we are drawing, and this here, this muscle is called the superficial transverse perineum muscle, which is transversing along that imaginary line. So that is the urogenital triangle. So what are the boundaries of the urogenital triangle? Urogenital triangle, this both sides you have the ischiopubic rami, and here you have the pubic symphysis at the apex, and this is the imaginary line which is formed above the superficial transverse perineum muscle. Anal triangle is the posterior triangle. This is consistent in both males and females. It is same. What are the structures you see in the anal triangle? Anal canal and anus. And there is ischioanal fossa, which is large fat-filled surface spaces on either side of the anal canal. These allow the anal canal to expand during defecation. So this is the anal triangle, the posterior one, which has the anal canal and the anus, and you have the ischiorectal fossa, ischioanal fossa or ischiorectal fossa. So here you can see the structures, the muscles. We'll go in detail about the perineum. What is the external genitalia is called vulva. Vulva has different parts. So what are the external landmarks? They are structures visible upon the external inspection. So whenever you are examining a patient, first we will see per abdomen, after that you see external genitalia. So we look for all these landmarks, external landmarks which are seen. Mons pubis, that is the rounded fatty tissue over the pubic symphysis covered with hair after puberty. Labia majora is the two longitudinal folds of skin that protect the inner structures. They are the female homologue of the male scrotum. Labia minora is the smaller hairless folds located medially. They meet superiorly to form the purpose of the clitoris. Vestibule, that is the almond-shaped area between the labia minora that contains the external urethral meatus, the vaginal orifice, and the openings of the Skene's and Bartholin's gland. So this is the vulva. So you have the mons pubis here on top, which is the fatty area which has hair. Then you have the purpose, that is the where the clitoris join. Labia majora is the larger one. Labia minora is seen below that. Majora is outer one. Minora is the inner one. Then you can see the vestibule, which contain the urethra, the opening vaginal orifice, and the here vaginal orifice, and here is the perineal body. We'll come to this perineal body. Here in this vestibule, also these Bartholin and Skene's glands open, they duct open into the vestibule. So what are the tissues seen deep? There are the erectile tissues and glands. So if you peel back the skin, that is you open the vulva, then you can see that clitoris, the primary center of sexual sensation. What does it contain? It consists of a glans, a body, and two crura that attach to the pubic arch. So vestibular bulbs, two masses of erectile tissue on either side of the vaginal opening, homologous to the bulb of the penis. Bartholin's gland is a greater vestibular gland. They are located at the 4 and 8 o'clock positions relative to the vaginal opening. So they secrete mucus for lubrication. So what is the significance of Bartholin's gland? Sometimes the Bartholin's duct, that opening, the duct gets blocked and it can become infected, and this leads to Bartholin's cyst or abscess. This is one of the presentation, one of the clinical problems that patients come with, Bartholin cyst or Bartholin abscess. So this is the clitoris, urethral opening, labia majora, outer one, labia minora, the inner one, vaginal opening, and here's the perineum anus. Now, what is the innervation of and blood supply of the vulva? Nerve supply is primarily the pudendal nerve, S2 to S4. The anterior part of the vulva, that is the mons pubis, is supplied by the ilioinguinal and genitofemoral nerves. Blood supply, that is by the internal pudendal artery to the deep structures, and the superficial skin is supplied by the external pudendal artery. So it's all, you have to remember pudendal. Pudendal nerve supplies, gives the nerve supply, and pudendal, internal pudendal artery and external pudendal artery. Lymphatic drainage is the vulva primarily drains into the superficial inguinal lymph nodes. So this is very important. When there is cancer of vulva, will first spread to the groin, that is the inguinal nodes, and not to the pelvic nodes. So superficial inguinal nodes will be palpable. So what are the changes that occur in vulva during pregnancy? They become soft, and varicosities also may develop. So this becomes, there is probability of bleeding during delivery. Vulval edema is seen in severe preeclampsia. So because of this, there is difficulty in episiotomy, and also the episiotomy healing also could become impaired. Now going on to the muscles of the perineum. There are two groups of muscles, the superficial and the deep perineal pouches, and they are demarcated by the perineal membrane. So these muscles are responsible for supporting the pelvic viscera, maintaining the continence, and facilitating the sexual function. So these muscles are important, and they are divided into superficial perineal pouch and the deep perineal pouch. So these muscles lie just deep to the skin and the superficial fascia. Primarily, they are associated with the external genitalia. So they are divided. The different muscles are ischiocavernous muscle. That is location. It is covers the crura of the clitoris. What is its function? It compresses the crura to maintain the clitoral erection by impeding the venous return. Bulbospongiosus, that is surrounds the vaginal orifice and covers the vestibular bulbs. What is its function? It acts as a vaginal sphincter weakly and assists in the expression of the secretions from the vestibular glands. Superficial transverse perineal muscle that runs from the ischial tuberosity to the perineal body. What does it do? It stabilizes and strengthens the perineal body, which is the central tendon. So these are the muscles. First is the ischiocavernous muscle. Here you can see the ischiocavernous muscle. Then you can see that is here is the mons pubis, the clitoris, the urethral meatus. Here is the superficial transverse perineal muscle, that is the transverse one from which goes from the ischial, both the ischial tuberosity, and they join at the perineal body. This part is the perineal body, and bulbospongious muscle is the one which surrounds the clitoris, vaginal orifice. Now going on to the deep perineal pouch muscles. These muscles are located between the perineal membrane and the pelvic diaphragm. So they are again different muscles are there. External urethral sphincter. This is encircles the urethra and provides the voluntary control over urination. So very important in controlling the urine. Deep transverse perineal muscle, that is deep to the superficial perineal muscle, which runs between the ischial rami. Same, they run in the same one, but deeper to the superficial one. What does it do? It supports the pelvic floor and helps fix the perineal body in place. Compressor urethrae or ureterovaginal sphincter, these are specific for female anatomy. They provide additional support to the urethra and the vaginal opening. So this is the perineal body here. So these deep muscles lie deeper to these muscles. I will be coming to it. What is the perineal membrane? It is a strong triangular fibrous sheet. This is located in the urogenital triangle, that is in the anterior triangle of the perineum, and they stretches between the ischiopubic rami. They form the inferior boundary of the deep perineal pouch. So what are the attachments? Laterally, they attach to the ischiopubic rami, anteriorly to the pubic symphysis, and posteriorly to the perineal body. So this perineal membrane runs in the anterior triangle or the urogenital triangle. This is the perineal membrane. So they laterally they are attached to the ischiopubic rami. This is the ischiopubic rami, this both side, and superiorly to the pubic symphysis, and their lower border is the perineal body where they are attached. This is the perineal body. What are the structures that pass through this perineal membrane? Urethra, vagina, vessels, and the nerves to the external genitalia. What is its function? It supports the pelvic organs, provides attachment for the external genital muscles. They help to maintain the urinary continence. Now going on to the posterior triangle, that is the anal triangle, posterior part of the perineum. Boundaries are the anteriorly, it's the line between the ischial tuberosity. Posteriorly, it is the coccyx, and laterally, it is the sacrotuberous ligaments. What are the contents? Anal canal and anus. Major structures in the posterior anal triangle is the external anal sphincter, ischioanal fossa, pudendal nerve, and internal pudendal vessels. What is its function? It functions help in defecation and support of anal canal. So this is the anal triangle. So posteriorly, this is the posterior triangle. Ischio here is it is and its borders are the imaginary line between the ischial tuberosities. Posteriorly, it is the coccyx, and laterally, it is the sacrotuberous ligaments. This is the sacrum. Sacrum is here, so sacrotuberous. From the ischial tuberosity to the sacrum, the ligament is present. That is the lateral boundary. And what does it contain? It contains the anal canal, anus, and this is the ischiorectal fossa or ischioanal fossa. Okay. Now, the perineal body, why is it so important? It is also called as the central tendon. So, most important clinical landmark in the perineum. It is an irregular fibromuscular mass located in the midline between the vaginal vestibule and the anal canal. So what is its function? It is the anchor where several muscles, that is levator ani, bulbospongiosus, transverse perineal muscles, all of them converge at this point. Why is it significant? In childbirth, this is the structure that is protected or incised during episiotomy. A tear or weakness here can lead to a pelvic organ prolapse. So that is why when we are suturing, we make sure that the episiotomy is sutured well, and the muscles, if there is a third degree or third degree tear, then may we repair it carefully so that the muscles on the sphincters are intact. So this is the perineal body. It is between the urogenital triangle and the anal triangle, and all the muscles, levator ani, and all the muscles get attached here. The deep superficial transversus perineal muscle, the deep perineal muscle, all the muscles gets attached at this point. So, what are the muscles? Bulbospongiosus, superficial. What is its function? Constricts the vaginal orifice, assist in clitoral erection. Ischiocavernous muscle, which is also a superficial muscle, which maintains the erection of the body. External anal sphincter is again superficial but deep, and it maintains fecal continence. External urethral sphincter is deep muscle which maintains urinary continence. What is the nerve and blood supply of the perineum? It has a very specific master nerve and artery, that is the pudendal nerve, which is from S2 to S4 for the primary sensory and motor nerve. What is the clinical significance? Pudendal nerve block is something which is performed by injecting anesthesia at the level of the ischial spine to provide the pain relief during the second stage of labor. Also, when you are doing any perineal repair, like Bartholin's or marsupialization of Bartholin's cyst or abscess, you can give a pudendal nerve block. Any perineal repair can be done with a regional perineal nerve block. Internal pudendal artery is a branch of the internal iliac artery, and that provides the entire blood supply to this region. So this is the course of the pudendal artery. So it goes behind the sacrospinous ligament and the coccygeus muscle, and along with the pudendal vein, and goes to the pubic symphysis. And these are the perineal arteries. This inferior rectal artery, perineal artery, dorsal artery of the clitoris, these all supply the muscles of the perineum and the other structures of the perineum. Now, pelvic floor. Pelvic organs are supported in upright position by a fibromuscular floor that includes a pelvic diaphragm, muscles of the deep perineal compartment, and the perineal membrane. This will constitute the pelvic floor. So this is the pelvic floor with the pelvic muscles and the perineal membrane and the pelvic diaphragm. So what is a pelvic diaphragm? It is the muscular floor of the pelvic cavity. It separates pelvic cavity from the perineum. What are the components? Levator ani, which levator ani is a muscle which contains three muscle groups, that is puborectalis, pubococcygeus, iliococcygeus muscle, and coccygeus, that is also contains ischio-coccygeus muscle. What is the function of this pelvic diaphragm? It supports the pelvic viscera, that is bladder, uterus, and rectum, and also maintains the urinary and fecal continence. It resists increased intra-abdominal pressure. What is the relevance of this? If the muscles are weak, then it will lead to pelvic organ prolapse. And it is also important in childbirth. So this is the pelvic diaphragm, which is formed by the puborectalis, pubococcygeus, iliococcygeus. This is the coccygeus muscle, and this provides the this is the puborectalis, prerectal fibers of the puborectalis, and these muscles together form the pelvic floor or the pelvic diaphragm. So what clinical implication of the pelvic floor? It is pelvic organ prolapse, that is descent of uterus, bladder called as cystocele, or rectum, that is the rectocele. Due to weakness of the pelvic diaphragm, or prolapse can occur. Again, urinary incontinence leading to stress incontinence, urge incontinence, fecal incontinence because of the weakness of the levator ani or clinic anal sphincters. Obstetric trauma, muscles or pudendal nerve injury during childbirth can cause obstetric trauma. Chronic pelvic pain because of pelvic floor muscle spasm or dysfunction. So what is the management for all for the pelvic organ prolapse and the problems of the pelvic floor? Kegel's exercise is what we advise all patients after vaginal delivery, or if they have a first degree prolapse. Physiotherapy also, is also useful. Pessary can be used for prolapse, and otherwise surgical repair. Now we are going to the internal genital organs. So what are the internal genital organs? Ovaries, fallopian tubes, uterus, cervix, and vagina. So uterus, this is the uterus, and you can see the fallopian tube and the ovaries on both sides. Uterus again is connected to the vagina through the cervix. So first we'll learn about the ovaries. Ovaries are paired almond-shaped organs in pelvic cavity. They produce the egg or the ova by the process called oogenesis. They secrete hormones, that is main hormones, estrogen and progesterone. It is attached to the by the ovarian ligament and the suspensory ligament. We will be seeing all this. What are these functions? Oogenesis, that is production of ova, and secretion of hormones, that is estrogen and progesterone. So the ovary has a cortex which contains the follicles, medulla which contains the blood vessels and the nerves. What is the blood supply of the ovary? Ovarian artery, which is a branch of abdominal aorta. And what is the venous drainage? That is the ovarian vein. So this is the cut section of the ovary. Here you can see ovary which is almond shaped or oval shaped on either side of the uterus, and they are attached by the ovarian ligament and the infundibulopelvic ligament on either sides. And here is the cut section of the ovary, which shows the cortex and the medulla. Cortex will contain the follicles. So follicles, when they are small, primordial follicle, then they become primary follicle, then they'll start become developing follicles, then they'll one of the follicle will become dominant follicle, that is the mature Graafian follicle. Then this follicle will rupture, and then ovum is liberated. Again, after the ovum is liberated, it becomes a corpus luteum, and then this corpus luteum will become regresses and will become the corpus albicans. So this is the function of the ovary, and you can see in the cortex or in the in the medulla, that is the inner part, the blood vessels are present, both the ovarian vein and the ovarian artery. Branches of the ovarian vein and the ovarian artery will go inside the ovary. So that is the structure of ovary. Now going on to the fallopian tubes, it's also called as the uterine tubes. They are also paired muscular tubes, which is approximately 10 centimeter long. They extend from the uterine cornua to the ovaries. What are the parts of the tube? Infundibulum, that is with the fimbriae, ampulla, which is a site of fertilization, isthmus, and the interstitial part or the intramural part. So this is the diagram of a fallopian tube. So this is the fimbriae. Then you can see the infundibulum. Fimbriae is close to the ovary, and you have the ampulla and isthmus and the interstitial part, which is towards the uterus, which connects to the uterus. So what is the function of a fallopian tube? It captures the ovum after the ovulation, and it's also the site of fertilization. So the fimbriae will catch the ovum, and the fertilization most commonly occurs in the ampulla. This is the ampulla. Here is where the fertilization occurs. After fertilization, they'll traverse through the isthmus, interstitial part, and then get implanted inside the uterus, usually at the fundus. Then they will transport the zygote to the uterus. So what is the blood supply of the fallopian tube? They are branches of the uterine and the ovarian arteries. Now we are going to the uterus. Uterus is the hollow pear-shaped muscular organ in the pelvic cavity. They are located between the bladder, which is anteriorly, and rectum posteriorly. It is divided into the uterine corpus or the body and the cervix by a dividing line, that is the internal os. So this is the uterus. So uterus has the uterine part is called the corpus or the body, and this is the cervix. So uterus again has the fundus, which is the top anterior part, and this is the corpus or the body, and here is the internal os. External os is this internal os. So about from the internal os to the external os is the cervix, supravaginal cervix and postvaginal cervix, and this will connect into the vagina. So approximately the size is 5 centimeter is the body, 2.5 to 3 centimeter, 3 to 3 centimeter is the cervix, and then it connects to the vagina. So the corpus or the body is the largest part of the uterus between the fundus and the isthmus. Triangular isthmus is this area where the just above the cervix and the lower part of the uterus is called the isthmus. This area, this narrowed area is called the isthmus. So triangular cavity in the coronal section. So you can see the coronal section in which it is a triangular cavity, and it communicates with the uterine tube, that is fallopian tubes, at the superolateral angles. So this is the whole structure of the uterus. You can see the body of the uterus. This is the fundus of the uterus. Here it is connected to the superolateral part. It is connected to the fallopian tube. This is the intramural or the interstitial part of the fallopian tube, isthmus part of the fallopian tube. Then you have the ampulla. Then you have the infundibulum, and then fimbriae. Then you can see the ovary. This is ovary, the ovarian cortex, and the ovarian medulla. Here uterus, again different layers of the uterus. You can see the endometrium, the inner layer, the myometrium, the in-between layer, and the parametrium, which is the outer layer, or the serosa of the uterus. And here you can see the ligament of the ovary that is connecting between the ovary is connected to the uterus by the ligament of ovary, and this is the suspensory ligament of the ovary where the ovary is connected to the tube. And here you can to the lateral pelvic wall. And here you can see the broad ligament of the uterus. This is the which has meso-ovarian, mesosalpinx. This is the mesometrium, and this is the round ligament which you can see traversing through the broad ligament. And this is this whole is the broad ligament. And here we'll be in detail seeing all the ligaments. And here you can see the cervix opening into the vagina. Now the layers of the uterus. Endometrium is the functional layer which is usually shed during the menstruation. Basal layer regenerates endometrium. Myometrium is the thick, smooth muscle layer responsible for labor contractions, and perimetrium is the outer serous covering or the peritoneum. What is the blood supply of the uterus? Uterus is supplied by the uterine artery, which has different branches, that is arcuate, radial, and spiral arteries. Functions: it's a site of implantation. It helps in fetal growth and development, and also expulsion of the fetus during childbirth. Now the uterus connects to the lower narrow cylindrical part, which is the cervix, 2 to 3 centimeter long. Connects the uterine cavity to the vagina. What are the parts? Supravaginal part and the vaginal part, which is projecting into the vagina. It has two openings: internal os, which opens into the uterine cavity, and external os to the vagina. Cervical canal has the mucus glands, forms the cervical mucus plug in pregnancy. What is its blood supply? Branches of the uterine artery. Clinical relevance is the external os from which we take pap smear for screening. Cervical incompetence, that is the length of the cervix becomes short during second trimester, can cause cervical insufficiency and incompetence. Carcinoma of cervix is also a common cancer in women. So this is the cervix. You can see from the isthmus, this is the internal os, and here the external os. This portion is the cervix, and it connects to the vagina. Vagina, it is the fibromuscular canal, which is approximately 7 to 9 centimeter long. It extends from the cervix to the vestibule. It has anterior fornix, posterior fornix, and 2 lateral fornices. So the posterior fornix is the deepest, and it is related to the pouch of Douglas. So this is the vagina. So you can see the sagittal section where vagina is related anteriorly to the urinary bladder and the urethra, and posteriorly it is the rectum. Posterior part is related to the rectum. And here is the anterior fornix and the posterior fornix. Now in the coronal section, you can see the lateral fornices. These two are the, both sides is the lateral fornix. This is the vagina. What are the layers of the vagina? It has mucosa, which is formed by the stratified squamous non-keratinized epithelium. Muscular layer is by the smooth muscle and the adventitia. Blood supply is vaginal and uterine arteries. Nerve supply is by the pudendal nerve, which is the lower part of the pudendal nerve. What is its functions? Copulatory organ, birth canal, and passage for menstrual flow. What are the changes in the uterus during pregnancy? The size and weight of the uterus increases. The normal size, pre-pregnancy size is 70 grams and it becomes around 1000 grams. Capacity expands significantly. Shape, which was pear-shaped, will become globular and then ovoid. Myometrium starts hypertrophy and hyperplasia of the smooth muscle occurs, and there is increased vascularity during pregnancy. What happens to the endometrium? Endometrium becomes the decidua. So decidua, again, 3 layers: decidua basalis, capsularis, and parietalis. Blood supply, there is marked increase in uterine blood flow. There are so many collaterals that are formed and plexus that are formed, and increased blood supply to the uterus. Lower uterine segment, again, the isthmus part of the uterus, that is the lower part of the uterine body, starts becoming thinner and thinner and forms the lower uterine segment during late pregnancy. Braxton Hicks contractions are irregular painless contractions that occurs during the last trimester, third trimester, or towards the end of the pregnancy. Ligaments of the uterus and cervix. So the uterus and the cervix are supported by ligaments, and when these ligaments become weak, that is when the prolapse occurs. So the broad ligament, which is a double layer of peritoneum, this supports the uterus, tubes, and ovaries. Round ligament of the uterus, this extends from the uterine horn to the labia majora. This maintains the anteversion of the uterus. Uterosacral ligaments, that is from the cervix to the sacrum. So it is sacral, uterosacral, from the cervix to the sacrum, that supports the cervix posteriorly. So when we are doing a hysterectomy, we go from top to bottom. So first is we do the round ligaments, then we go to the broad ligament, then you go to the uterosacral ligaments. So this is the round ligament, is the first ligament that we encounter. So first we cut the round ligament. Then this is the infundibulopelvic ligament, which attaches the ovary to the tubes and the lateral wall, pelvic wall. And this is the ovarian ligament, where the uterus is attached to the ovary. And here is the broad ligament. This whole area is the broad ligament. Cardinal ligament is also called as transverse cervical ligament, from the cervix to the lateral pelvic wall. This is the major support of the cervix. So this contains the uterosacral and the cardinal ligaments are the major support for the cervix. So they contain the uterine vessels. Pubocervical ligament is cervix to the pubic bone, and this supports them anteriorly. So this is the pubic symphysis. So pubocervical ligament is anteriorly supporting the cervix to the anterior pubic symphysis and the anterior abdominal wall. Anterior support it gives. And this is the transverse cervical ligament, which supports the cervix transversely, and the uterosacral ligament, that is the uterus to the sacrum. So you can remember is at sacrum. So that is posteriorly. Transverse will support transversely and sacrum will be posteriorly, and pubocervical is pubic symphysis is anteriorly. So what are the contents of the cardinal ligaments and parametrium? So ureteric canal goes through it. descending cervical artery, lymphatics and lymph nodes, and Frankenhauser plexus. These are the contents or the structures that goes through the cardinal ligament. So this is a diagram showing ureter, uterine artery, and the lymph node and the Frankenhauser plexus. This is called the ureteric tunnel, this area. So what is the attachment of ovary? Infundibulopelvic ligament attaches the ovary to the lateral pelvic wall and the ovarian ligament to the uterine cornua. Meso-ovarian lies between the ovary and the broad ligament. So this area, there's like a flimsy, like a layer of that is seen between the tube and the ovaries. So that is called the meso-ovarian ligament. Now the genital structures are over. We have to pelvic ureter is a very important structure which we have to know, because we often encounter this in our surgeries. So pelvic ureter is the continuation of the abdominal ureter into the pelvis. It enter the pelvis by crossing the pelvic brim at the bifurcation of the common iliac artery. So what is the course in females? So you have to know the course of the ureter, because in some surgeries when it is difficult, or you might have to trace the ureter, because without injuring the ureter. So they descend along the lateral pelvic wall. They'll pass beneath the uterine artery. So this is called the water under the bridge phenomenon, because the water is ureter, urine is as the water, and it is going under the bridge under the uterine artery. They enter the urinary bladder obliquely. So what is its relation? Close to the cervix, it's approximately 2 centimeter lateral. So when we reach the cervix, 2 centimeter laterally, you might encounter the ureter. So when we are doing the uterosacral ligament or uterine artery clamping, that time we have to be very careful not to go too laterally to in that case, if you go too laterally, you might encounter the ureter. Related to the ovarian vessels superiorly. And blood supply is branches from the uterine, vaginal, and all the internal iliac arteries. These are the arteries which supply the ureter. Clinical importance, risk of injury during hysterectomy, and it is site of ureteric obstruction. So this is the course of the ureter. Ureter enters the pelvis, crossing the bifurcation of the common iliac artery. So the common iliac artery is this. Aorta divides into common iliac artery. So at the bifurcation here, the ureter enters the pelvis, and it descends. It descends down, and when it reaches here, that is 2 centimeter lateral to the cervix. This is the cervix. 2 centimeter lateral to it, the uterine artery will cross, and this will go below it. The ureter will go below the uterine artery. This phenomenon is called the water under the bridge phenomenon. The uterine artery crosses the ureter, and then you can see that the ureter goes very close to the anterior vaginal wall and enters the urinary bladder. Here again, you can see the ureter coming from the kidney, and then reach here is the where the it enters the pelvis. So bifurcation of the common iliac artery, and then here the ureter. This is the ureter crosses here, and water under the bridge. Blood supply of the female internal genital organs. Ovaries, it is easy to remember, branch of abdominal aorta, ovarian artery, and they anastomose with uterine artery. Uterus is supplied by the uterine artery, which is a branch of the internal iliac artery, and uterine arteries branches are arcuate, radial, and spiral arteries. Fallopian tube is supplied by the tubal branches of both uterine and ovarian arteries. So these are the main blood supply of the internal genital organs. So here you can see this is the ovarian artery, which is a branch of the abdominal aorta. Abdominal aorta direct branches ovarian artery. Ovarian artery again gives different branches, ovarian branch, and this is the tubal branch which goes to the tube. This is the ovarian branch, and here you can see the uterine artery, which is a branch of the internal iliac artery. Again, this gives branches, arcuate, spiral, and radial branches. And here you can see the vaginal artery, which is again branch of the internal iliac, and they supply the vagina. So branches of the internal iliac: aorta, common iliac, divides into internal iliac and external iliac. Internal iliac has two divisions, anterior division and posterior division. The anterior division has branches, that is superior vesical artery, obturator artery, uterine artery, middle vaginal artery, middle rectal artery, inferior vesical artery, inferior gluteal artery, and internal pudendal artery. And you can see the external iliac artery. So internal iliac artery branches is an important question. Branches of uterine artery, again, as I said, it gives arcuate artery, radial artery, and again radial artery, and this uterine artery again anastomosis with the ovarian artery. Cervix is supplied by the cervical branches of the uterine artery. Vagina is by the vaginal artery, which is a branch of the internal iliac artery. This is also gets contributions from the uterine and the internal pudendal arteries. What are the venous drainages? Uterine and vaginal venous plexus from drains into the internal iliac vein. Ovarian vein drains into the IVC, right side into IVC and left side to the left renal vein. So this is the venous drainage. Here you can see the both the arterial and the venous drainage. What is the lymphatic drainage of the internal genital organs? The ovaries lymphatic drainage is para-aortic lymph nodes. Fallopian tubes is para-aortic nodes and internal iliac nodes. And uterus is fundus to the para-aortic nodes, along the round ligament to the superficial inguinal nodes, body to the external iliac nodes, cervix to the internal iliac and the sacral nodes. Vagina again upper 2/3 to the internal iliac nodes and lower 1/3 to the superficial inguinal nodes. So these are the nodes of the lymph nodes of the pelvis that drain the genital organs. Para-aortic nodes you can see here. Nodes at the aortic nodes is at the bifurcation of the aorta. Common iliac nodes, internal iliac nodes are here. External iliac along the external iliac artery, and obturator nodes and parametrial nodes. Here you can see the sacral nodes. So you can see from the uterus, it drains into the para-aortic nodes and internal iliac nodes. The vagina node drains into the superficial inguinal nodes, lower 2/3. So nerve supply of the internal genital organs. Ovaries are supplied by the ovarian plexus, sympathetic, that is T10 to L1. Uterus is by the uterovaginal plexus from the inferior hypogastric plexus. Sympathetic is from the T12 to L2. And parasympathetic is from the pelvic splanchnic nerves, that is S2 to S4. So this is the lumbar sympathetic trunk, aortic plexus you can see, and the hypogastric plexus. And here is the pelvic sympathetic trunk and sacral plexus you can see, S1, S2, S3, and this is the pudendal nerve. So these are the main splanchnic and somatic nerves of the pelvis. Cervix is supplied by the uterovaginal plexus. Vagina upper 3/4 by the autonomic, that is the uterovaginal plexus, and lower 1/4 by the pudendal nerve. Pain pathways, that is the fundus or the body, they go to the T12 to L2 sympathetic fibers, and cervix or upper vagina to the parasympathetic, that is S2 to S4. So when doing surgery, we have to know at what level they have to give the regional anesthesia. Now going to the last topic, that is brief about the pelvic ultrasonography. So before we go to the ultrasound, we have to know the anatomy and physiology of how you can see the structures in an ultrasound. So uterus, you know that it is bordered by the bladder anteriorly and the rectum posteriorly. So in most women, the uterus is anteverted, which indicates that the uterus is superior and posterior to the bladder and anterior to the rectum, with the uterine fundus more anteriorly oriented. So you know that it is anteverted. But women may also have antiflex, retroverted, or retroflex uterine orientation. So these are things which you can notice in the ultrasound when there is an anatomical change in the uterine position. The uterus has a hyperechoic stripe in the center of the fundus and it communicates with the cervix. So you can see a thin line. This is the hypoechoic stripe in the center, which will communicate with the cervix. So that is the central line, which we say the cavity. Distal to the cervix is the vaginal canal, which appears as a hyperechoic line when viewed with a transabdominal transducer. So here you can see that urinary bladder is here, right ovary, left ovary, and this is the uterus, and this is the transverse section. Ovaries are seen like this, right ovary, and this is the left ovary with a dominant follicle. So this is how you see in a ultrasound the pelvic structures. Adnexa, right adnexa, left adnexa, uterus, urinary bladder, and the ovaries. In the adnexa to either side of the uterus, there is the right and left ovaries. They classically lie between the lateral uterine wall and the internal iliac vessels, which is a relationship more likely altered in multiparous women. It might be altered. The adnexa also will include the fallopian tubes connecting the uterus and the ovaries, both of which should be carefully evaluated, as normally in an ultrasound, we won't be able to see the fallopian tubes, but when there is an ectopic, there is a adnexal hydrosalpinx, or when the fallopian tubes are enlarged, that is when it will be seen. So adnexa should be carefully looked at. Ovaries classically have a slightly hypoechoic echo texture compared to the surrounding tissue, and they look like a chocolate chip cookie, characteristic due to the peripheral anechoic follicles. So the follicles are present peripherally, and when there is polycystic ovary morphology, you can see multiple cysts, which are polycystic follicles, which are arranged peripherally around in the ovaries. So large corpus luteal cysts are also commonly seen in early pregnancy, typically as a single large simple cystic structure within the ovarian tissue. Corpus luteum cysts will involute as the placenta develops to support the growing fetus. So this is the ultrasound diagram of a uterus. You can see the cavity, this line that is seen in between this is the endometrium, and this is the cavity, this line. Here again you can clearly see the uterus. This is the uterus, and this is the bladder, and this line, this will communicate to the cervix. This is the corpus luteal cyst. Here is the corpus luteal cyst with peripheral color flow. When you put color Doppler, then you can see the peripheral color flow. Now, ultrasound is can be done by transabdominal ultrasound or transvaginal ultrasound. Abdominal transducer is commonly used for obstetric imaging. So its frequency is about 3 to 5 megahertz, which provides sufficient penetration and resolution. What is the depth? It can go up to 12 centimeter for a 2.5 megahertz transducer and 6 centimeter for a 5 megahertz transducer. So curvilinear probes are preferred. Transvaginal transducer, their frequency is 5 to 10 megahertz for early pregnancy. Transvaginal probes are not usually used beyond 12 weeks, except for cervical length or localizing the low-lying placenta, because the transvaginal scans are usually used for gynecological cases more, and in pregnancy only up to 12 weeks. Condom is used on a transvaginal probe to prevent transmission of infection from one woman to another. So these are the probes. This is the curvilinear transabdominal probe, and this is the transvaginal endocavitary probe. So there is an orientation marker which is located on the ultrasound transducer. Here you can see the marker here. This is the marker. And it helps to orient the image on the screen with respect to the right and left of the mother. So when you place that marker, you know which is the right and which is left of the mother. Gel is placed on the patient's skin for transabdominal, on the vaginal probe for transvaginal scans. Prevents air from coming between the transducer and the tissue. It also acts as a lubricant. So the probe glides easily over the abdomen or along the vagina. So we usually put a gel over it. So this is transabdominal scan, how it is done, and that is how the transvaginal scan. So the position differs in both the scans. So the transabdominal, as I said, curvilinear. So what are the requirements or the differences between transabdominal and transvaginal? In transabdominal, you need a full bladder, and in transvaginal, you have to ask the patient to empty the bladder. And the probe is on the abdomen, the other one is inside the vagina. Image, it's moderate, but transvaginal, you can get a high resolution imaging. View is panoramic view is seen in transabdominal, but in the view is limited. It's a limited area only you see, but it is very useful in gynecology. So best for transabdominal is for late pregnancy and large masses. You can use transabdominal because you can see a wide view is there. And transvaginal for early pregnancy and detailed pelvic scan, it is useful to use transvaginal scan. So like normal size uterus, endometrial thickness, polyps, growth, normal ovaries, follicles, small masses and pouch of Douglas, all for all this you can use transvaginal scan. Transabdominal scan.
Doctor, you can unmute yourself now.
Okay. So transabdominal scan is a non-invasive ultrasound examination of the pelvic organs, which is performed by the from the anterior abdominal wall. So what are the indication for transabdominal ultrasound? It is evaluation of uterus, ovaries, in early pregnancy assessment, pelvic pain, masses or in fibroids or in AUB. Preparation is you have to have a full urinary bladder which acts as an acoustic window, and it will also push the bowel loops away. Usually the bowel loops comes in the way, so this full bladder will push it away. Structures, what are the structures that you see? Uterus, you look for the size, the shape, the endometrium, the ovaries, the size, the follicles, any cyst is present. Adnexa, you see whether it is enlarged or whether any adnexal mass is there. Urinary bladder, and you always look for free fluid in the pouch of Douglas. What is the advantage? It is non-invasive. You don't have to do any invasive it's not an invasive procedure. It's very painless. It's not at all painful, and you can have a good overview of the pelvic anatomy. The limitation is that it is less detailed when compared to transvaginal. Transvaginal scan will give you a detailed and a clear picture of your the pelvis. And sometimes obesity and bowel gas will also reduce the image quality. Transvaginal scan is internal pelvic ultrasound performed using a high frequency probe which is inserted into the vagina. This will provide detailed imaging of the pelvic organs. What are the indications? It is early pregnancy assessment, ectopic pregnancy, in infertility evaluation, that is follicular monitoring, in AUBs, in any ovarian cyst and masses. So this is how a transvaginal scan is done, by inserting into the vaginal canal, and then you can visualize the, so this, it will visualize the local, that locally and in that but it will give you a clearer picture. So here you can see it is very clearly, you can see the uterus, and as you move around you can see the adnexa and the ovaries, bilateral ovaries and the adnexa. So you need empty bladder, the empty the bladder, and probe is covered with a protective sheath or with a condom or a gloves. Structures visualize uterus, cervix, ovary, adnexa, and in early gestational sac. What is its advantage? Higher resolution than the trans-abdominal scan, better visualization of small structures, that is early pregnancy, when it is a small sac, or when it is ectopic pregnancy, all those are visualized better, and it is not affected by the obesity or bowel gas. Limitation is that it is invasive. You are introducing a instrument inside, and it may cause mild discomfort. Some patients feel discomfort, and it is not suitable for some patients, like if they're having if they're seropositive or anything, then we might not be able to do. And then unmarried also, we won't be uh, performing a transvaginal ultrasound. So pelvic ultrasound, summarizing, you do pelvic ultrasound when there is pelvic pain, postmenopausal bleeding, abnormal uterine bleeding, dysmenorrhea, abnormal or technical difficult pelvic examination. Sometimes we may not be able to assess PV in PV, and in case of amenorrhea, in pelvic infection, abnormality noted by other imaging, infertility, congenital anomalies of the genital tract, any delayed or precocious puberty, post-operative pain or bleeding or infection, if you want to localize your intrauterine contraceptive device, screening for cancer in high-risk women, urinary incontinence or pelvic organ prolapse as a preoperative for guidance. So these are the indications for a pelvic ultrasound to be done. And what all organs do you see? Uterus, its size, shape, orientation, endometrium, myometrium, cervix, adnexa, you look for ovaries, the size in 3 dimensions, dilated tubes if present, mass if it is there, then you have to measure the size, and the sonographic characteristics, that is adnexal masses, you look for their wall, whether it is thick walled, if there are any internal septations, if there is any papillary excrescences. So based on all these findings, you can we can classify your ultrasound findings, you can classify them as low risk or the high risk, that is benign or malignant. So then cul-de-sac or the POD, look for fluid, any mass, if there is a mass, then size, position, shape, and their sonographic characteristics. So by this we come to the end of this class. Any questions?
Thank you, doctor. Thank you for having this session. Doctors, the Q&A session is open. You can drop in your questions on the chat box. Meanwhile, you can scan the QR code visible on the screen to submit your feedback and to get your certification registration done. I will also drop the link for the certification registration on the chat box. Please click on it. Doctor, I think we have few questions. I'll read it out for you. Supriya Wadarkar is asking, can you tell me when and how uterus is formed in the fetus? How is the fallopian tube made? Oh, there are a lot of questions from doctor. Uterus बनने का process क्या है ma'am? We know the basics, but we want in details about that part.
I think we can have another class on the development of the organs, because it's another topic itself. This topic was just the anatomy of the female pelvic anatomy, but development of all the internal organs, female genital tract, is another class itself, the embryology and development. We can have another class on that.
Cool, doctor. We'll keep you posted, Supriya. Please follow us on social media. We might announce this particular class very soon. Dr. O.P. Gautam is asking, what are the USG findings in dysmenorrhea?
Dysmenorrhea. Dysmenorrhea, basically the cause of dysmenorrhea can be primary dysmenorrhea, secondary. So primary is the spasmodic one, which normally anyone can have, which is normal. But the congestive type of dysmenorrhea, that is pathological. So pathological dysmenorrhea is caused by any pathology. Most commonly, it could be adenomyosis or endometriosis. So for adenomyosis, we look for the thickness of the myometrium. If the myometrial wall is thickened and there is loss of myometrial endometrial junction, that means there is adenomyosis. So these are the findings of, so you are looking for a cause for the dysmenorrhea, not the USG findings for dysmenorrhea, but you are looking for a cause for the dysmenorrhea. Endometriosis, you look for the endometrial cyst if it is present and the features of endometrial cyst.
We have one more question. Please intimate malignant benign tumor.
You mean differences between malignant and benign tumor? Benign tumor in an ultrasound is, again, this is I think I've already done a class on this benign ovarian mass. So the ultrasound features are, it's usually thin walled, clear, not solid. And in malignant, it will be thick walled with septations, and the wall thickness will be more than 3 millimeter. They will be usually benign ones are uniloculated, malignant ones are biloculated, multiloculated or biloculated, and solid tumors. And they can have papillary excrescences also. So there are different, all these findings are there. Separates the benign from malignant.
PCOS findings in USG.
PCOS finding is peripherally arranged ovary follicles in the ovary. So that is a classical picture of the PCO morphology. So there could be more than 20 follicles, which are around 20 follicles which are peripherally arranged, and the ovarian volume will be more, 20 cc or more. The ovary becomes bulky. So that is the feature of PCOS in ultrasound.
Which type of uterine fibroid is most common in treatment?
Intramural fibroid is most common, and treatment is differs about the age, the symptoms, the size. Depending upon that, the treatment differs. That is not part of this class. You can ask question, I think, towards this class.
We will surely coming up with a lot of such sessions, Dr. Afnan. Don't worry. Keep us tracked with our social media posters. You will get to know about that. How to find about PCOD and PCOD.
I think my next class is on PCOD.
Okay. Infix Smart, please wait till our next class. We'll be announcing our next class very soon. The dates are just not confirmed for the coming month, so you'll have to wait for it. This month already all the scheduled webinars have been posted on the social media. Please follow on it. I will also drop the link for our social media channel so that you can click on it and follow us on social media so that you will come to know about our webinars. Thank you, doctor. Thank you so much. I take this privilege to extend thanks from all of our doctors joining us this evening and shedding particular light on this particular topic. Thank you so much. Thank you, doctors, for joining. Good night.
Thank you.
I will be here for 2 more minutes. If anyone wants certificate registration form link, I will be posting.